Are people even aware of the seriousness of what's happening around hypertension, poorly controlled blood pressure? This is one of the most important issues that needs to be addressed at the moment in the pandemic. Now, what it seems to be happening is nobody can quite understand what's going on. Well, what I've got today is Dr. Shetty with me, and we are going to go through some of the patterns that we've observed and potentially what could be relevant for you. As usual, in the description, there's a link. There's a course that I did on hypertension. If you don't even want to do the course, make sure you get the PDF download for how you can monitor your blood pressure at home. Very, very important information. Additionally, I just wanted to highlight that coming up in just another day is the embalmer's clots. I am going to be doing this presentation trying to make sense of the science that we've got from the latest analysis. So if you want to join me, there's a link in the description below where you can join us in this process. Additionally, we have now been successful with Disease X. So thank you very much to all the supporters. We have just broken through the barrier. And so this is going to therefore happen, a collaboration with Lumientia. And we will hopefully get this out to you shortly. And here is the reward for anybody else who wants to get on board, is that we will give you the full breakdown of the excerpts from Malone. What's very interesting about this PDF is that for every section that we have, there is a QR link and a link that if you click on this, you will go exactly to the video where he was discussing this. So this is all the way through on the Malone discussion. All the way through, you have these QR codes with these links that will take you directly to exactly where he was talking in these three presentations, year 2022, 23, 24. So again, we appreciate everybody who has been supportive, and we look forward to any ongoing support in the near future. Without further ado, let's bring in Dr. Shankara Chetty. How are you, Shankara?
Hi, Philip. I'm doing well. I'm doing well. I hope you're doing well as well.
Excellent. Do you want to give us a quick update as to what's happening with your case?
Okay, Philip. I think the audience is aware that we gave the prosecution the option to go back and reformulate charges. They came back overnight with a whole new set of charges, which didn't follow the preliminary committee's recommendation, which by law should be done. So we ended up going back and forth. They insisting that they don't need the preliminary committee to recommend how to charge me, which is the medical board that's charging me in the first place. So when I looked at it, Philip, I think the end justifies the means. I could go to the higher court and ask that my rights be restored. I would probably get a date in 2026. And of course, the legal wrangling that follows will take us into 2028. And the lives lost in that time, I'm sure, would be devastating. So I chose to relinquish my right to challenge any legal process. I've accepted the charges as they are. So there's no reason for us to take it back to the preliminary committee. It's fine. But by relinquishing that right to challenge legal process, I retain my right to freedom of speech and expression. So on the 11th of November, we are having a virtual meeting to ensure that the prosecution has provided me with all the necessary details I require as to the charges against me and the clarification of those charges. And on the 10th of March next year, tentatively, I will be asked to plea and my case will start. So
Yeah.
I think it's 10th of March is better than 2028.
You know what's very sad. I recently will have and soon have a discussion with Dr. Shelton from New Zealand. When I spoke with Dr. Victor from Malaysia, and then you think of the people in the UK that have been targeted in Canada. When you think of Dr. Corey in the US and Dr. Marek, Dr. McCullough, you know, it's such a global move to try and silence people who have dared to try something different. It's almost as if the system is saying doctors need to stay within the boundaries that we have set them.
Yeah.
They don't need to look beyond it. And all the science is now owned and controlled by industry. And we have now become almost like advanced pharmacists, where all we do is prescribe what we are allowed to prescribe. That's a very sad thing. And I don't know if the clinical community understand how serious that is going forward.
Yeah, and I think as well, Philip, in that manipulation, they have also used the law to their advantage to silence us. Now, when I say I relinquish my right to challenge legal process, I realized that I had lost that right a long time ago, and there was no point in me trying to fight for it now. Legal process has been manipulated to the point where we have no rights. So I chose which right I'd like to retain. Not the right to legal process, but the right to the freedom of speech and expression. So I'd like my case to proceed. I'll accept all the
Excellent.
charges and I'll defend myself.
So yeah, so let's get straight into this clinical conundrum with regards to hypertension. So I know, because I've been observing it for a long time, that there are a lot of people whose blood pressure, either they get diagnosed with hypertension after they've had COVID, or their hypertension goes out of control for a period of time and is extremely difficult to control. And this is a pattern I've noticed for quite a while. What have you noticed in your practice?
A very similar kind of thing, Philip. I tend to see patients who've been through the mill, means gone through to specialist physicians, been hospitalized with very high blood, with pressure very high. But in all, the problem seems to be that these patients suffer with what I'd call a very labile blood pressure, a very fluctuant blood pressure. So they go into hospital with a high blood pressure, they put onto medication to try and stabilize it. And then at some point, it suddenly drops too low. And then they have to be taken off the medication. So it seems to be a seesaw on and off medication. Doctors are having great difficulty in trying to control blood pressure in the traditional ways that we have to control blood pressure. And I think there's underlying mechanisms that are contributed to by the exposure to spike protein and its effects that are not being considered. And I think the blood pressure problem we face is not necessarily hypertension, but a compensatory mechanism to other mechanisms at play.
Yeah, I think that when you think of the big one, I remember at the beginning of the pandemic when there was concern about ACE inhibitors, because we knew that the virus would potentially impact on that pathway. I was fascinated by the fact that even though we weren't sure the effects, it turned out it wasn't a problem, but there didn't seem to be any concern about ongoing use of ACE inhibitors. But we know that the renin-angiotensin system is specifically affected in the context of the hypertension. I think it's probably worthwhile trying to see if people can understand. I've got a slide here that this is a big point, and I'll try and see if I can show it, that people need to understand about blood pressure control. So this here is the angiotensinogen from the liver acted on by renin to make angiotensin 1, and then ACE acts on the angiotensin 1 to make angiotensin 2. And this is the one that drives the blood pressure. And the ACE2 is needed to convert it from angiotensin 2 into angiotensin 1 to 7 or 1 to 9. And this balance between the two is what keeps the one part of the blood pressure under control. So you can suddenly see that if anything disrupts ACE2, you'll have higher levels of angiotensin 2. And so, therefore, you would be at risk for higher blood pressure control. Now, in theory, you would think that an ACE inhibitor, which blocks this conversion, would therefore work better. But I don't necessarily see any clear patterns where any particular drug group is beneficial. So it suggests that it probably is something else.
Yep. I think, Philip, just to give the audience an understanding of what we have in our toolbox, and just to understand what blood pressure actually is, it's a pump and a system of pipes, and it's a closed system. The pump pumps through these pipes. So we have mechanisms to control the pressure in this closed system. The mechanisms we have, we can either slow the pump down, and so we have all these beta blockers that slow the pump. We can either decrease the force, keep the speed, but decrease the force. So we have medications like amlodipine, the calcium channel blockers. We can bleed the system, get some fluid out. We have diuretics to use. And of course, we can affect the diameter of pipes. That's where ACE comes into it. So we have all these mechanisms to lower blood pressure. And I've never been one to follow protocol of which medication follows which. I always look at what the underlying pathology might be to choose my first medication. Now, what we're seeing now is a problem where the blood pressure is reacting to something, and that's fluctuate with the vaccines, with the virus, with long COVID, and that can be immunologic, affecting the neurologic balance of your blood pressure and the contraction of your vasculature and all that kind of thing. It can be clotting, where you have fine microvascular clots far away from the heart itself, but the heart realizes that there's ischemia somewhere in the body, and so it will raise the blood pressure to try and compensate for that. It's the reason in strokes where patients have clots, we do not reduce their pressure too quickly. We can worsen the stroke because the increase in pressure is actually compensating to try and get blood flow to an area that's compromised. So we see all these fluctuant things happening. So looking at the underlying mechanism provides the solution to a stable blood pressure. And I think that's where we're missing the boat.
Yeah, I think and the problem is, is that people have always underestimated hypertension, which is why it's a silent killer, because it doesn't necessarily give you many symptoms. You're fine, maybe a little bit of headaches, but by the time you get headaches, it is almost very, very way out of control. And I usually emphasize to people is that when we heard of essential hypertension, they called it that because they didn't know if the blood pressure being elevated was actually part of the normal physiology.
Yeah.
And I think it was, can't remember which US president, on the day before he died, his systolic blood pressure was over 300,
Yeah.
and then he had a bleed.
Yeah.
So and at that time we weren't using medication, but it just shows you how significant hypertension can be. And the fact is, once the damage is done, you can't reverse it.
Yeah. I think as well, Philip, with hypertension, there is damage. What we're dealing with is not an illness in itself; it's a risk factor. Combined with diabetes and other risk factors, they cause endothelial injury, which results in atherosclerosis, which results in all the other problems that we have with cholesterol plaque formation, all that kind of thing. And the end result is strokes, heart attacks, which are the result of vessel injury. So hypertension, diabetes, all these kind of things are risk factors that contribute to vessel injury. And we as doctors, what we're trying to prevent is vessel injury. And unfortunately, vessel injury is silent and not very quantifiable, unlike your blood pressure. But blood pressure is an indicator that shows up far too late when the vessel injury is already occurred. Then your pressure starts to go up.
Yeah, so when we think about it, if you take out ACE out of the picture and ACE2, what else can we be looking at? Because as you said, it's quite fluctuant. So it's not going to be fluid overload, which we can manage with diuretics. You know, a lot of people may have issues like palpitations. So we could think that it is something to do with the control of the or the efficiency as to how the heart is manipulating the blood pressure, because it can slow down the heart rate if the blood pressure goes up. Maybe there is something in that that is
Yeah,
also part of the picture. Any thoughts?
yeah, autonomic dysregulation. With your vagus nerve being affected, that will affect a lot of different mechanisms, and so you'll get hypotensive crises, you'll get hypertensive crises. So when you look at blood pressure itself, there's so many different mechanisms at play that control it, from your kidney function to the innervation of your heart to the way anxiety and stress will influence that innervation. So we're seeing the fluctuant blood pressures and we're seeing the fluctuant pulses. But I think each patient needs to be individually analyzed to figure out what the predominant pathology underlying that actually is. We've established with COVID that we have immune dysregulation, immunopathology in many different forms that can influence it. We have coagulopathy in many different forms that influence it. And we have toxicity, either from the gut or from spike protein directly, that influence these different systems. So in every patient, you got to figure out which is the overriding predominant pathology. Is it coagulopathy? Is it immunity that's causing the problem? Is it toxicity in the gut? And when you address those issues, then the other issues become easier to address. So I think
You
it's
know,
patient specific.
one of the things that I remember that I tend to look at is sensitivity to salt. So meaning that there are some people who, when they reduce the salt in their diet, their blood pressure is easier to control.
Yep.
Not
And,
everybody. And
yep.
in that cohort who has salt sensitivity, I usually think that they're magnesium deficient.
Yep.
And just by them replacing their magnesium, just taking a supplement, very often they can stabilize that part of their blood pressure control. But it doesn't get much attention, even though magnesium is well known to be associated with poor controlled blood pressure and heart issues. It's again one of these things where, from a pharmaceutical point of view, there is no money in magnesium. It's on the supermarket shelf that anybody can get over the counter,
Yeah.
and so it gets no attention.
Yeah. And that's the reason it's not standard of care. The right way to do things would be look, hypertension is a silent but slow killer. So there's no rush for me to put you on a toxic medication that might cause you problems later on in your life. So I can try salt restriction for a short while and monitor your blood pressure. Magnesium, where magnesium comes into the picture, Philip, your arteries are surrounded by musculature. And when you're magnesium deficient, you get cramps.
Mm.
And so by being magnesium deficient, you increase the tension in your arterial system by a slight increase in muscle tone in the muscles around your vasculature. So by taking magnesium, you relax those muscles and the blood pressure normalizes. So we should be trying these simple mechanisms first. And when all else fails, then we go to the pharmaceuticals. So there's a lot we can do. These are not something that we got to do today. We got to recognize it today. We got to understand why it's there. We got to look at lifestyle. We got to look at the simple mechanisms first. And when all else fails, we do have our pharmaceuticals that do have their place. So yeah,
You,
I think it's just a mind shift.
I wonder whether or not there should be very clear public health guidance that everybody, after they've been infected with COVID, whether or not the symptoms were mild, should be monitoring their blood pressure for at least a period of time. Any thoughts on that?
Yeah, I think Philip, from what I've seen, a period of 3 years, because I've seen patients develop it 3 years after the vaccine, and yes, where there's no family history, there's none of these things, and I think with the affectation to the general physiology of the population, we're going to have to be a little more vigilant about our health. So I mean, the number of patients that I've seen developing diabetes since long COVID, since taking the vaccine, is astounding. The people that have developed all the other problems we talk about. So these are things that have become far more common. And so we should be far more vigilant for them and far more regular in our testing for these things.
Well, one of the things that I've been concerned about, and I'm trying to raise awareness, and depends on who you talk to as to how seriously they take it, is this risk with infection, reinfection, this cumulative effect that can happen that can damage the physiology over long periods of time. It's what I'm describing as that COVID storm, spike triggered immune responses that occur over a long period of time. And I think that people are judging the disease by the fact that for many people, the symptoms are mild now. And I'm trying to warn people that that's the same way that hypertension is. That's the same way even HIV presents. The first part of the infection in the first 4 weeks is relatively mild. It doesn't mean that the disease is mild and that
Yeah.
you can therefore relax and not worry about it. That's my biggest concern at the moment, is that people are just not taking it very seriously. Any thoughts?
Yeah. The mild long term sequelae will have far more implication on their health than the short acute phase of the illness. And that's the reason they ignoring it. Uh, look, Philip, in my practice, I educate all my patients that there's a specific time to recovery when you have a flu. We all know our bodies. So I'm usually telling an 80-year-old patient that they've lived with that body for 80 years, so they know it better than I do. And they know how long it takes to recover. And I expect that they recover in that length of time completely. If not, they must report it. Do not take any symptoms lightly. So I expect you to be back to full health, I'd say in a maximum of 2 weeks. And if not, there's some immunopathology that's been triggered, and you need to come back and have me stop that timelessly before it causes injury.
Yeah, so this is some serious stuff. And as I said, that the whole industry has become very, very reactive. And so I can predict what's going to happen in 3 years' time. They're going to find that there's this surge of complications of hypertension, heart disease, strokes, peripheral vascular disease, and then suddenly there's going to be a big push. We need people to check their blood pressure and so on, but it'll be 3 years too late. And the damage that has been done in those 3 years, this is a point people don't get. Once the damage is done, it can't be reversed.
Yeah.
You can slow it,
Yeah.
but you can't reverse it.
Yeah, and I usually explain that to my patients in a very that's funny way, Philip. Uh, you cross the road every day. There's a risk crossing the road. So to negate the risk, you look left and right a few times before you decide to cross. That is taking care of your health, either your pressure medication, making sure you're compliant with your treatment, all those kind of things. But a one-legged man and a blind man have a different risk crossing the road, and so they will be treated differently. And then on those days, you decide for a month, I'm not taking my medication, or I'm trying something different. It's like crossing the road blind. You might have made it across and not got knocked, but there's no point deciding to look after the accident. And of course, if you sit with other comorbidities like diabetes, and if you decide only to treat your hypertension, then it's like only looking left when you cross the road. There's half a chance of getting knocked. So I think people need to just understand that we live in this world of risk. And all we're trying to teach them is risk mitigation by doing simple uh, lifestyle changes and simple checks to make sure that you're safe.
As you were talking there, these are standard pieces of information that would come from almost any doctor, any clinician. But one of the big problems that I'm hearing, even in among the company environment, is that patients, because of what happened in the COVID pandemic, have lost almost complete faith with the system. And so, even though the advice is still good, they almost will not take it because they no longer trust the people who are giving it. How do we get around that?
Philip, that's a very tough thing to get through. Uh, I'm constantly seeing patients who've been ill for the last 2 years, uh, ever since they've either taken the vaccine or had COVID. And they've been through all manner of clinicians, physicians, to try and solve the problem. And they've got no help. But the one overriding thing, I had a patient last night who had the first symptom after taking the vaccine within 15 minutes, developing a severe headache, and has never been the same since. But she's been through every single institution. She's been diagnosed with POTS. I can't tell you the number of diagnoses that she's been through. But the thing she told me last night was not a single doctor was willing to entertain the thought that this might have been caused by the vaccine, even though the symptoms started within an hour of taking that vaccine. We need to get past that. If we're going to get anywhere, we need to accept first that there is injury that's been caused. Then only can we start to build some confidence back into our medical community. If doctors are going to disregard what patients say, then they're not going to go back to them.
Have we ever done this before? I'm trying to think that, this is such a massive error that the clinical community has done because I don't think people understand that in theory, if we are using a new medication, and actually I was thinking about this recently with all the push that is going with some of the newer drugs, the semaglutide, the Ozempic push. And I'm saying that the responsibility of the clinicians is to be extra vigilant because you're using it in a way that you haven't used it before. You're using it in conditions that you haven't used it before. And so it requires extra vigilance to actively look for problems. What we have seen here is that instead of having that position of actively looking for problems, clinicians have taken the position to disregard information from patients. It's a very unusual thing that would suggest it's more psychological than it is anything to do with standard approaches to practice. And I don't think I can think of a situation where this has ever happened before. And it just shows you the power of what has happened across the pandemic to influence clinical staff across the board. So it's not just doctors, it's all clinical staff. They will not contemplate, even when it is the only option that is in front of them, that this could be linked to the symptoms. It's very, very strange.
Yeah, I think Philip, this question was asked before. How do we restore the faith in the medical fraternity? And unfortunately, this is going to lead to a division. It's going to lead to a division. We've seen the egos and the arrogance. And so I think what we need is a redefinition of who the true medical fraternity actually is. And that's something, a choice people have to make. Remember that the medical fraternity is being co opted by Big Pharma to do their bidding. We're supposed to be doing the bidding of our patients. And at the end of the day, I think people are wise enough to recognize who's doing their bidding. And that's going to split the medical fraternity. So it's not up to us to do this, it's up to the patients to make the right choices.
Yeah, I think that as we close out, Shankara, I think that in terms of, I warn people that there was always a transition that was coming in medicine when you bring in AI and technology and so on. That was always coming. But the COVID pandemic and the loss of trust has accelerated this so quickly that I don't think that anybody can predict how quickly patients are going to move with their feet, meaning that they are at the moment voting with their feet. And the moment they are choosing not even to see their clinicians, very concerning. What will they do when we bring AI in and we recognize that artificial intelligence can actually do sometimes in some conditions, a very, very good job. Is this going to destroy the foundations of the way how we interact with patients almost forever?
I think it will, Philip. I think it will. We've seen what Google has done. I get my patients coming in with their Google searches of everything that afflicted them, and yeah, the anxiety levels are through the roof with it. AI has its place. It can be used for great benefit. My concern is that it will be manipulated and it will be used for commercial interest. AI should be something that's available to clinicians to come to differential diagnoses, to give better understanding of things. I think, like medical knowledge, it should be limited to those with an understanding for it. Otherwise, it'll create a whole lot of panic amongst people. But it has surely accelerated the move towards looking to AI for solutions with people. So, yeah, I think we've got to be careful about who's managing the AI in the first place and providing it.
Excellent. Thank you again, Shankara. This is, as usual, quite insightful. I'd just like to remind the audience, look in the description of the video, you will see the links. The important one is one to hypertension. You don't have to do the course, but the module that has the PDF, which will give you your home blood pressure monitoring, is for free. Make sure you get that if you've got hypertension. So again, thank you everyone for joining us. And again, just a reminder about Disease X. If you want the Malone book, ebook, then please just go there and you'll be able to get it. Any contribution will open access to it. So we really, really appreciate the support so far. So thank you again, Shankara. I'll just ask you to wait with me for the outro. And until we meet again with our audience, have a great evening.
Thanks, Phil.